today we are going to review non-invasive ventilation. So the physiological goal of non-invasive ventilation is to improve gas exchange by resting the respiratory muscles and increasing alveolar ventilation. So what this is going to do is it's going to reduce diaphragmatic pressure swings. So CPAP helps offset auto PEEP because it's going to splint those airways open. And then pressure support facilitates inspiration. And it increases tidal volume, which is going to increase MAP, which is mean airway pressure. So by resting the respiratory muscles, we're going to increase tidal volume. We are going to decrease CO2. It leads to better oxygenation. Which is going to lead to a decrease in respiratory rate, which is going to lead to helping our patients get back to their baseline before they go too far and they need to be intubated. So remember, non-invasive ventilation can be used in the acute care setting and also the chronic care setting. So let's review some disease processes. So COPD and non-invasive ventilation. So it's for an acute exacerbation. Because with COPD, they have an increase in airway resistance. So that would be RAW. RAW is airway resistance. And they have an increased respiratory rate. So that's going to lead to hyperinflation and auto PEEP. And then hyperinflation leads to auto PEEP. So let's start at the beginning. So hyperinflation will also lead to increase in respiratory muscle work. And then that is going to increase their oxygenation needs because we need to get more oxygen to the tissues. And that's going to increase demands for ventilation because those tissues are now releasing more CO2. And this leads to further air trapping. Which leads to hypoventilation. And then their CO2 is going to increase. And then their muscles are going to get tired, so they're going to have muscle fatigue. We want to try and avoid muscle fatigue because if they get to that point and they just poop out, then they're going to need to be intubated. No longer will non-invasive work. to help support those muscles. So we want to prevent this from happening when they start working hard to breathe. So therapies include, with non-invasive ventilation, we're going to give them bronchodilators. We're going to give them anti-inflammatory agents, oxygen, antibiotics if it is needed, because a lot of the reasons for an acute exacerbation of COPD is infection. And then we're going to put them on ventilation. So we are going to put them on BiPAP. So remember, COPD, they need to be put on BiPAP because they are having an issue with CO2. And what BiPAP is going to do for our COPDers is it's going to decrease the muscle workload. It's going to decrease their respiratory rate. And it's going to increase their tidal volume to help prevent air trapping. So let's talk about asthma. So we are typically going to start with CPAP, and then if it's needed because we see that there's an increase in their CO2, then we will move them to BiPAP. So this is going to improve gas exchange. It's going to decrease CO2. And then within 2 hours, you should see an improvement in vital signs. One more disease process I want to touch on real quick is CHF. In CHF, if they are not responding to drugs or oxygen, then we will put them on non-invasive ventilation. So this is putting them on non-invasive ventilation is going to expand the alveoli. And when that happens, we're increasing oxygenation, decreasing their work of breathing, increasing their FRC, and then improving lung compliance. And what it's doing is it's overcoming their critical opening pressure. So when they first start, when you first put them on non-invasive ventilation, to start, you want to start in CPAP. And you want to start their CPAP at 8 to 12 centimeters of water pressure. Now, if that doesn't work, then you move to BiPAP. So some initial settings. Remember, I'm going to put this over here. EPAP equals CPAP, which equals PEEP on mechanical ventilation. This is what you use for oxygenation, all of these. Okay, so some initial settings. So IPAP is usually set 8 to 10 centimeters of water pressure to start. EPAP is typically set at 4 to 6 centimeters of water pressure. And then remember, with pressure support, you need a minimum of 4. And pressure support is IPAP minus EPAP. So let's say we started out at an IPAP of 8. So we have an IPAP of 8. Then in order to meet a minimum of 4, your EPAP would be 4. Now you could go up on the IPAP from here. So say you wanted to increase to 10, you could leave your IPAP at 4 because you have a minimum of 4. But if you increase the IPAP, or excuse me, the EPAP of 4, you would have to increase the IPAP so you have that pressure support as a minimum of 4. So if you increase the IPAP to, let's say, 6, you would have to increase that IPAP as well. So then you'd increase IPAP to 10. Let's draw this out. So we are going to say that this is our breath. So this down here is going to be our EPAP. This is going to be our IPAP. And this in here is the breath. That's the tidal volume. So anytime that they are above baseline, so this is baseline, that's how big their breath is going to be. So let's say here we have an EPAP of 5 and an IPAP of 10. So this here is our pressure support. So remember, IPAP is what you change for CO2, equals CO2, and EPAP is what you change for oxygen. So if we have a patient who needs increased oxygen, so now for the next breath, we want to increase the EPAP. So we'll say that this is still 5 and this is still 10, but we change it while they're taking that breath, so it's not going to come down as far. So we just increased the EPAP to 6. So we're still within pressure support because this is 10, this didn't change, but you can see that this breath is now smaller because this is our new baseline compared to the breath before. So we've helped oxygenation, but we've decreased the tidal volume, so they may retain more CO2. So if it's just an oxygenation issue, you can leave it like this. If there's CO2, if they need to blow off more CO2, then we'll come down here and we'll say that this is 6, and then we'll increase it to 12. So every time you increase IPAP, you're going to increase that tidal volume. So we'll say this one was 12. We're still at 6 here and here. But if we increase it to 14, you can see how much bigger the breath is going to be. So when you're looking at the readout on the screen of their tidal volume that's exhaled, and it's not to quite where you want it, they're not quite at their ideal body weight goal, then you could increase the pressure support. So if you increase the pressure support, see how we've increased it from these two? If you increase pressure support, you're going to increase that tidal volume. It's important to know with non-invasive ventilation what you should adjust. So for patient comfort, you can decrease the respiratory rate because it's not mechanical ventilation. They are going to trigger their own breaths. They set their own respiratory rate. Our respiratory rate is just for backup. So if we set a rate of 10, every 6 seconds, they're going to get a breath delivered. So if you have a backup rate and it's at like 14 and the patient's awake and they're not using it for some sort of sleep apnea or shallow breathing while they sleep, at higher rate, may be annoying to them. It may drive them crazy and they may not be comfortable. So you can decrease the respiratory rate. You can also adjust the rise time, which is how fast the patient gets the breath. If you are having a CO2 issue, you're going to want to increase that IPAP. So you're going to adjust IPAP, which adjusts the pressure support. If you have an oxygenation issue, you are going to adjust the EPAP. But remember, if you adjust the EPAP, you need to increase the IPAP so that you maintain the same pressure support, so that you can maintain the same tidal volume. If it's still an oxygenation issue, remember we can adjust the FiO2, but we want to use the 60-60 rule. So if a patient is already at 60% FiO2, then we're going to want to increase the EPAP as much as we can. We want to try and avoid those higher oxygen levels when possible. When should we wean, and how should we wean non-invasive ventilation? So weaning can take hours to days. There's no specific protocol or established weaning techniques. The most common approach is to attempt time on and off the machine. So you will have patients, especially in the ICU, or patients who first start non-invasive ventilation, and they have the mask on, and they are so thirsty because their mouth is dry from all this air going into their oral cavity, and their throat is dry, and they just need a drink of water. So you agree to let them take a drink of water, you take the mask off, and then as soon as they lose that pressure, you can start to watch their sats just drop. Then you come back once they've rested, maybe they've slept, and they've been on the machine for a few hours, and they want to try again. And so they tolerate it for 5 minutes this time. So that is typically how weaning non-invasive goes. So you give them periods of being more comfortable and seeing how they tolerate not being on the machine. But if you see them start to use more accessory muscles again, or their heart rate increases, or their respiratory rate increases, their sats drop, then you're going to want to put them back on the BiPAP. Let's interpret some ABGs. So let's say your patient comes in and they are at this. So this would be a respiratory acidosis with moderate hypoxemia. So you get the patient and you put them on BiPAP and you start them at an IPAP of 8, and we'll say an EPAP of 4. And they are on an FiO2 of 40%. So before you can take another ABG to see if it is working, you have to wait a minimum of 30 minutes to an hour. When you change, for example, if you change PEEP on the mechanical ventilator, you need to wait an hour so that those lungs can be opened and have that gas exchange to know if it's truly going to work. So we'll say it's The doctor told you once you place him on BiPAP, you wanted to repeat ABG in 30 minutes. So we'll say that it's 30 minutes later. So this is our new ABG. Not much has changed, slightly. So you're thinking, okay, well, oxygenation's looking better. So let's change the IPAP because we need to be able to blow more CO2 off. Let's increase that pressure support. So now you change him to an IPAP of 10. You're going to leave the EPAP because he's headed in the right direction. So now instead of a pressure support of 4, you have a pressure support of 6. And you're going to leave the oxygen alone. So the patient has a bed now in the ICU, so they're going upstairs. So the next gas is over an hour later. So our third gas is much closer to normal. So your bigger breaths and your increase of pressure support has helped them. So now you're just going to let the patient ride. All right, let me know if you have any questions. When we get to emergency care, we are going to go over non-invasive ventilation again.